The president of Results for Development Institute. It's a pleasure for us to host this meeting of the DC Health Systems Board session, of which we've hosted others before, so we feel close to this. For those who are not familiar with it, the board was established in 2008 to provide a forum in the greater capital area for discussion and debate about current issues in health systems research and policies relevant to low and middle income countries. The board's discussions concern both research about health systems and current policy issues, and we are going to be happy to anyone who is not yet a participant to make that possible and enable everyone to get future mailings. This particular session builds off of work being done by the Future Health Systems Consortium, which is a research consortium funded by DFID in the UK, and working to improve access, affordability, and quality of health services for the poor. It's led by the Johns Hopkins Bloomberg School of Public Health, of which there are quite a few suspects here, as we'll discover. The consortium links research institutes across the globe, working in Bangladesh, Uganda, China, India, and Afghanistan. And we have several people here from IDS as well. I understand there's a practice, and we're going to follow it here, of doing brief introduction, everybody introducing himself or herself. Please not your full life story. Just, your name and who you're connected with. And why don't we start at the very back, Martin?
Marty Martin, Results for Development.
I am Lane Goodman with Results for Development Institute.
I continue the trend. I'm Meredith Kimball, also with Arcady.
I'm Manuela Villar. I am a PhD student at Hopkins.
I'm Malka Koshua, and I work in healthcare governance of community life science and Yunqing Wang from China National Health Development Research Center.
I'm Krishna Rao from Johns Hopkins.
I'm Leah Massman from George Washington University.
Sarah Bennett, also from Johns Hopkins.
I'm Kavi Bhara from Johns Hopkins.
I'm Rita Harding from the World Bank.
David Fishai from Johns Hopkins.
Bruno Boucher, Fishai 360.
I'm Jerry Booth, Institute of Development Studies in the UK.
I'm Catherine G from IFPRI, but formerly from IDS.
And Jeff Knezovic from the Institute of Development Studies in the UK.
Alexis D'Agostino from JSI.
Susan Genie, Broad Branches Business.
Great. Rob?
Robert Hecht, Results for Development. David Peters, Johns Hopkins.
You could say it as a speaker. I'll get a little vibe.
Well, I'll say more when I talk.
Okay.
Elizabeth Kirapa. I'm from Makerere University in Uganda.
And please also, when you speak, say a little bit more about yourself.
I'm Lee Fredman with R4D.
Great. And I think we're going to start with two videos. And I think after the videos, I will introduce two people whom you'll see, I think, and who aren't here. But let's see if we can accomplish the incredible and get the videos to work. Let's give it a shot.
My name is Tanit Adam, and I work in the Alliance for Health Policy and Systems Research, which is based in WHO in Geneva. And just to start by saying thank you very much for this opportunity to share a few words about systemic thinking and its relevance to health systems. And I'd really like to start with building blocks of the health systems that have been usefully used by some to try and conceptualize where to intervene in the system, where there are system problems, how can you address them. But probably we have spent a lot of time to try and think of them in isolation, and the point I'm trying to make is that it's really time to think more about the interactions and the relationships between them and how complex it is, how they affect each other, how they are governed by the actors of the health systems, and how the people are really central to decisions and to actions in the system. And often we really conceptualize interventions from the supply side, where even in conceptualizing them, we talk about with supply side people. We don't pay much attention to really try and seek the demand side people as well. So these are all important points to try and understand why policies work or not work, especially that often many answers are very counterintuitive and surprising, unanticipated, and that's really key to system thinking and complex adaptive systems. So I'm sure that many of us would ask, when is this relevant? Is everything requiring a system thinking approach? And I find it useful to think of the distinction between how complex the intervention or the policy is and how much of a system-wide effect one expects from that policy, and really putting them in a spectrum where the more complex the policy is and the more of system-wide effect you expect, the more it warrants a system thinking approach. Obviously, there is a spectrum of that, and most interventions, one would argue, have system-wide effects, but that's a useful way to think of when to use it, and also the scope of how complex one can go. The other point I wanted to make is most of us have really been trained to think of problems as their individual components, and we think that by understanding the details, we can really address the problem and explain it and conclude into what sort of outcomes, or depending on the questions we have. Me, one of them, physicians, nurses, even epidemiologists. But what system thinking requires is really a different set of skills that really respects or think about behavior as generated from the system, think of the interactions between the different components of the system. It really thinks of the system as a cause to whatever happens as a response to a certain intervention. It thinks of this as internally driven from the behavior of the system and its actor, rather than think of the system as an external factor that one needs to control for. So it doesn't think of it as for example, as an influencing factor. It think of it more as a causality. And of course, the most important thing is to really go away from this very linear approach of input, output, outcome, process, impact, to more of a very dynamic process where there are feedback and the system is constantly changing, and how can one use methods to be able to capture this complexity, this dynamic behavior, and so on, which is really what we're trying to push for. I'd like to then maybe conclude by a few thoughts about how can this sort of thinking be used, because very often one say, okay, this makes a lot of sense, but how can you really apply it to health system question? And I can think of at least 4 examples. One can use it to understand a problem, why a certain intervention is not working, why the system is weak or needing to be, or behaving that way, why a particular policy is working in one place but not really in the other. So understanding a problem, it can also be used to design or redesign intervention in a more system-respecting way, taking all that complexity in mind. It can certainly improve evaluations of policies and interventions by taking into account elements that capture complex adaptive system phenomena and try to understand it and explain it and then intervene or propose solutions for it. And finally, it can be used to explain or generate new theories about complex behavioral phenomena or complex reactions to policies, or how the system behaves, that one can learn from, also to inform other interventions and designs. So linked to the science of delivery, I think it's very relevant in the sense that one would like to know why we are not able to scale up interventions to scale, or how can one deal with issues with implementations, for example, reaching higher coverage when coverage is still low and we don't understand why, because it worked in other places, even within the same country, but in different contexts. So system thinking in this case is very, very instrumental in trying to understand different behavior, resistance to change, counterintuitive behavior, and so on. So there are several tools that I'm sure today will be presented in the following presentation that can deal with this. But it's certainly key to be able to do anything useful and a step forward really in trying to ensure effective delivery of interventions, because otherwise we'll just continue doing the same thing and not really be able to implement things to scale and ensure that they will be sustainably continuing to be implemented, because the system is so clever and just keep changing all the time.
Great, and we're going straight on to the next presentation.
Hi, I'm Ben Ramalingam. I'm a visiting fellow with the STEP Centre at the Institute of Development Studies, and I'm also the author of a recent book, Aid on the Edge of Chaos, which seeks to apply ideas of complex adaptive systems to international development, public health and humanitarian work. When we're thinking about applying systems thinking to the science of delivery, there are at least 4 broad types of approaches, classes of approaches, that we can engage with. The first are approaches that enable us to think about systemic complexity, to understand how a particular phenomenon actually works, how it's shaped by feedback, by interdependence, by interactions between the different parts of a system. The second set of approaches enables us to understand behavioural complexity, how individuals think and how their thinking shapes how they behave, and how individual behaviour aggregates to overall group behaviours. The third set of approaches are about relationships. They're about the relationships between individuals, between entities, between concepts and ideas. And the basic idea is that there are networks which really govern how we communicate with each other, how we learn, how everything from group dynamics through to the ways in which diseases spread across a population. The fourth and final area around understanding dynamic process complexity, how change actually happens, not the lovely straight line graphs that we often see in our theories of change, but actually the non-linearity of change, the fact that it's characterised by surprise and by tipping points. And I think those 4 broad approaches that help us think about systemic complexity, about behavioural complexity, about relational complexity, and about dynamic complexity, together provide a structured alternative to the standard operating assumptions of development and indeed of health systems work. And I think if we can engage more with these approaches, they provide us with new tools and techniques for thinking about how to deliver in the face of complex problems. Now, the particular relevance of complex systems thinking and the tools that I've just outlined for the science of delivery is that we often focus our research on ex-ante design, on thinking about how an initiative or a problem might work. We have generally very weak monitoring through a process, and then we tend to then focus a lot of researchers on the evaluation of our interventions, our initiatives. And I think what the science of delivery in particular needs is a stronger emphasis on operational research, on implementational research. And while there has been some increasing awareness of this, and there have been handbooks developed, for example, by the WHO, in general, this is not something that is well integrated into the way our sector does things. The home of these tools and techniques of systems thinking, of network science and so on, in other sectors that have really operationalised them, is indeed in implementation research. It's about understanding that these tools can help guide decision-making in real time. And that's the kind of effort that we need to make. We need to invest in these tools, not just as ex-ante or ex-post research techniques, but as a way of helping making decision-making around delivery more effective as delivery is happening.
Great, so those are our first 2 speakers, very efficiently delivered, and because they don't have a chance to introduce themselves other than what you've heard, let me just add, they're well known to some people, but maybe not to everyone here. Tagreed is a pediatrician and health economist at the Alliance for Health Policy Systems Research in WHO. And she has also worked in the Egyptian Ministry of Health, as she mentioned. And Ben Ramalingam, as we heard, has been a freelance consultant and writer, visiting fellow at the IDS, and as he mentioned, published a book on complexity sciences. And prior to joining the development sector, he worked in strategy consulting and investment banking. So in addition to solving your health systems problems, if you have personal investment problems that you want to solve, he's your man. A few people joined us since we did a round of introductions. For those of you, welcome. It's great to have you here. And we did go around the room just so that everybody would have a sense of who's here. So I would invite those who came in after we did that to introduce themselves now.
I think you're the first in the back.
I'm Bruce Lee. I'm a faculty at Johns Hopkins School of Public Health, Department of International Health.
Great.
William Wells, Senior TV Technical Advisor, USA.
Great.
I'm Jeremy Hardy. I'm a master's student at Emory University and an intern at USA.
Great.
I'm Ann Lynn. I currently work at Deloitte Consulting. I'm also a student at Johns Hopkins.
Great.
I'm Nicholas Dudinsky. I'm with the USAID Office of Health Systems.
Hi, I'm Bhargavi Amu. I also work in the Office of Health Systems at USAID.
Perfect. Great. So we're going to keep rolling here, and our goal is to have our speakers, our real live persons, be as efficient as our virtual persons. So David Peters will go next and help me to make sure he stays within his allotted 10 minutes.
Sure. So cut me off when
But before you do, and then we'll have, I just want to give people the run of show so they know what's coming. And then Elizabeth for her 10 minutes. And then Rob will pull together everything that was said, and in 5 minutes we'll summarize the entire state of this complex science. And we're keeping it sort of disciplined in time so that we have plenty of time for open discussion. And our goal is to finish by 7. And so with that, David, please begin, and feel free to introduce yourself a bit more.
Sure. Well, I'm not going to say that much more. I'm a professor at the Department of International Health and I'm part of the Future Health Systems Research Consortium and working on implementation issues, which is really why we're here today, to talk about how systems thinking can contribute to implementations, to the delivery science or the implementation research. And so I want to first start off by, well, maybe this isn't going to work. I thought
I'll do it.
You
just have to signal to me.
Yeah,
All right,
okay.
let's send this. I can send this down your way.
Okay. Sounds good. I must have had a block on there, so sometimes technology fails and sometimes
it's complex.
There we go. So my first point is that we actually all use systems thinking, and this is because systems thinking is really the thinking that goes behind how one thing leads to another. It's about how do you put things together, how they're connected to each other, to some notion of some whole entity, which is actually the origin of the word for systems. When we think of how X leads to Y, if you're trying to think about how any kind of outcome, whenever you do research or any kind of action where you think if I'm going to do an intervention, something else is going to happen, you're really talking about systems thinking. This is a kind of connection. So what this really is about is trying to come up with the models of system thinking that are a little bit more disciplined and follow different approaches. And so, the first thing is, we all do it, just like those of you who have small kids knows, everybody poops, right? So we can get over that problem. So I think the real question is, this is a field that has really developed in a number of scientific areas in the last 70 years or so. And so it's really a question of which of these theories, methods, and tools in this field are most useful for in particular settings. And I would argue that the problems of health delivery are particularly needful of systems thinking, and I would say particularly of those kind of tools that involve complexity science. So that's really some of the talk. I think I can stop here at need be, but I'll try and give some rationale, further rationale behind this. So when we were trained in science, we were trained to use Occam's razor, this principle of greatest simplicity. There are other reasons why people want to move beyond this. People have this sort of the Wile E. Coyote set of aesthetics. That is, there are simpler ways to catch the bird, but the complicated ones really kick butt. So there's another sort of tendency to try and make things a little bit more interesting. But I would say that's not really the reason we want to do this in and the problem of delivery. We do have a common type of quest, and that is to try to find sustainable solutions to improve health of everyone, or at least of our focus at Hopkins and in our research consortium is around disadvantaged people around the world. And having put this, we don't have to make things complicated, but it is about understanding complexity, understanding the world around us, which I will argue is actually quite complex. Having said that, we do have some magic bullets. We have vaccines, we have vitamins, we have antibiotics. We have a lot of things that in and of themselves we think of as quite simple, or simple types of interventions. But when you see what happens in practice, even the most simple medical intervention often involves complex social interaction. And yet the type of approaches that we bring to research and understanding have really been quite simple. The dominant paradigm in research is really this one around evidence-based medicine, evidence-based policy, which has contributed enormously to our thinking and policy in medicine and public health and other areas. And really the emphasis has been on showing cost-effective solutions that have been shown to save lives. Here's a few publications that have embodied some of this. Some people were involved in some of these landmark documents. And they're important for being able to show what you can do under certain conditions. But the conventional pathway to improving health services in global health is really one that needs to move beyond that. We start off with choosing the right intervention, which can be based on cost effectiveness. We then set common ambitious targets, and here's the Millennium Development Goals. We fund them ambitiously, so here's 4 new funding mechanisms that have occurred in the last 15 years, and then we simply implement them as designed with this cookie-cutter type of approach. And this is really where the problem, or one of the areas where the problem breaks down. We try to find the simplest type of solution, find X, but we can often be wrong by trying to be simple. We need to get beyond the simplistic to be as simple as possible with a better understanding of how things work. So let's look at some of these international paradigms, or international challenges. One of them is with the MDGs to try and reach 90% service delivery. So I've used a simple model here, and each line represents a country over time, and it's simplified to a linear change of how it's improved or changed skilled birth attendance around the world. Which you see at the top line, which doesn't project on a screen like this, that's the target, 90%. And the other one there, the other line, red line, is the average condition. So what you find in this kind of situation is that no country is really average, that the pathways are really quite different. So some divergence from the notion of reaching a common target. The other MDG goal is about child mortality. Here the same, each line represents a country, its own pathway. And you can say that perhaps some countries that start off with low mortality tend to stay that way. But again, each country follows its own trajectory. The target would suggest they all have similar slopes, but in fact, when you do the analysis, you show that the starting point and each country's slope contributes far more than any kind of average. So even when you try to simplify it, we find that reality doesn't reflect the way we behave in terms of setting targets and expectations. We also find, this is a spider graph, or radar diagram. This is showing the ratios between rich and poor between 6 common types, similar types of primary healthcare interventions. And what you see here as regional areas is that the ratio, the pattern of inequity is different across each service and across each country, each region. We've actually aggregated the regional. So again, if implementation is about reaching particular disadvantaged or those who need it, the ability to do this is not something that's following some common pattern. There's divergence in patterns. Being able to implement effective interventions, this is a PMTCT cascade of things that need to happen. We see the implementation challenges are huge. And so even though when we know what the right thing to do is, being able to deliver on that, we get difficulty in managing. So these are some of the reasons that we have problems with implementation. So what I'm trying to show is a picture of complexity around implementation. We know this is a book that reviewed service delivery globally, well, in low and middle income countries. We do find that many interventions work in pilot or research conditions. This is what most of the research is about, most of the literature. But faults are common in real world conditions. We find many things that can work. We have 200 interventions in the disease control book, or more than that actually. But it's hard to replicate them in much detail. Policymakers often define strategies, but their influence over how they're implemented is quite limited. Strategies do achieve objectives, but many unintended and unpredictable consequences. So that we really find that the way implementation works is really quite a bit divergent from the way we plan them. How you implement matters a great deal. And so when you looked across these kind of strategies, what we found, this is basically using different types of study designs, but this notion of adaptation, involving communities, flexibility and modifications through stakeholders, how you implement these things is probably as important as actually picking something that you know can work under more controlled circumstances. So the lesson from implementation experience is that there isn't really a blueprint that you can follow, a magic bullet, even if the intervention, the technology itself might be a magic bullet. But a learning by doing approach is needed, and this kind of flexibility is really the kind of approach that you take when you're addressing complex and changing conditions. So my argument is that we really need these complex systems models to the health sector because we don't have control, because people learn and adapt, and things don't go exactly as planned, unintended consequences. These behaviors are divergent from just a simple type of implementation. So we wrote Ligia Pena and I wrote a little thought piece a couple of years ago that really shows the kind of patterns that we see in terms of change over time. And these kind of feedback mechanisms, these kind of networks, phase transitions, emergent behavior, these are the way we see things actually working when we describe them, understand them, but we don't have the typical types of tools to be able to deal with those dynamics. The typical, for example, regression models or experimental designs don't work well with these kind of phenomena. We need other kinds of tools. This is just showing a typical kind of poverty and ill health feedback that we try and intervene and break it, but these are things that are hard to research from simple designs. In the interest of time, I'm going to skip over some of this, but one of the problems we have with implementation is that we try and do one thing at a time without then thinking about broader effects. And so here's a number of titles of people who have looked at some of these. Sarah is in the room actually in terms of system-wide effects of the fund, and others have worked on this problem. I wanted to show you briefly about about some empiric work that tries to connect some of these, because it's rarely actually done that you can look over time to see how an intervention in one area actually affects others. So what Toru Matsubayashi, a former doctoral student, did was he put together all the data from 5 years from the Uganda HMIS system and tried to track whenever PEPFAR funding came in. And PEPFAR funding is huge because this is probably equivalent in most years to the total Ministry of Health budget. And then tried to see how did that affect the rate of change of HIV services and non-HIV services. So followed it over cohort and modeled the intervention of the PEPFAR funding. And so we don't need to go into the details, but these are sort of rate ratios of changes in how things work. And what you see on the left side, HIV services, as you would expect, they're all above zero relative risk. So PEPFAR has had a positive impact on all the HIV services. What you see on the non-HIV services, some are positive and some are negative. And interestingly, the biggest effect on anything is actually the reduction in injectable contraceptives. And then the other thing that's quite interesting, I'm going to stand up here, is that antiretroviral therapy actually didn't show a statistical effect, but you saw a huge variation in bigger variants that occurred as a result. Now, there's some explanations for that, and one of them has to do with antiretroviral doesn't get captured in the HMIS system. They have a separate system, and so you get more variants because it's sporadic. And the injectable contraceptives was something that there was fear about HIV actually being transmitted through injections, and so we saw some other effects. But other services, both positive synergies and negative. So this is one of the challenges in global health in many countries, is really around trying to figure out how one thing leads to the other and being able to capture those synergies. So let me give one last example, and I'm going to. This is actually some of Bruce's work that we Bruce Lee in the back that we have that shows a good example of modeling with complex adaptive systems modeling to really address a problem about immunization, delivery of immunizations, literally the supply chain of immunizations in Benin. But it's something that they've worked on in a number of countries with this platform. So the problem was, first of all, getting vaccines to the population. They actually have pretty good coverage, but they're still not getting to everyone. And they wanted to introduce new vaccines, in this case, rotavirus vaccines. And it was felt that there were probably some efficiency gains that could happen in the vaccine supply system. So what they tried to do with a number of partners, WHO, AMP, and I'm not sure who the others are, but Bruce, you can tell us later.
UNICEF and the Gates Foundation.
Gates Foundation. Okay, so they tried to evaluate the supply chain, and this is a rather elaborate model. Not all the models are big, but this one is rather elaborate, and they were trying to identify what the bottlenecks are, calculate it could improve efficiency, and develop a more effective as well as efficient supply chain, maybe looking at alternative ways of delivery at lower cost. So that's what they're trying to do, raise the effectiveness and its efficiency. So the interesting part or one of the interesting parts is actually this whole process, which involves close engagement of a group of modelers, implementers with the Ministry of Health over time, in terms of understanding the problem and trying to understand the system, the supply chain as it works. After that, collecting data, and then based on that, trying to develop some scenarios, alternative policy scenarios about how to implement better, using some models, using the actual system that we'll talk to you briefly about, and then leading into some direct decision making. So this model is they basically collect models, data about every level of the supply system. At the bottom, from every vaccine and diluent to every refrigerator where it's supposed to go to, at each level of the system, from the transport and everything, each piece along the chain. They then put it into the equations in terms of how they relate to each other, in terms of how long it takes, how much it costs, how many people are involved, and they have a structure, a software structure, and the model is basically a discrete event simulation model. And what it then pulls out is the results in terms of how many get vaccinated, how many things get wasted, what kind of costs, and so you end up with these kind of economic outcomes as well as public health outcomes as well. So here's the model as it was, and I'll go quickly through these last ones. But you have a system where it comes in through UNICEF to a national store to, I think, 7 departments, but there are 8. And then I think about 80 different communes at a regional store, and then going to the store. And you have certain knowledge about how much they are, how available they are at each level, and some costs involved, and as well as a system where they're delivered through at the periphery level through motorcycle transport. Then they tried to look at, well, there's some other options. So one of them on the left involves reducing the number of those lower levels from 80 communes to 34 zones, and getting rid of the motorcycle pickup to maybe each goes and picks it up to these trucks that go around. The other option is to get rid of this altogether, and again, the same choice between those two. So again, this is a model where they're able to take real data and then put some simulations. And here's what they found. So this is comparing capital costs of a change, they want to keep those low, and operating costs, and they want to keep those low. So here's the status quo here, the different models. And then here is one where they could keep it at the zone sanitaire. Here's one where you just remove the departments. And these 3 triangles here are again with this, putting in this zone sanitaire and different amounts of loops. So what you see here is just putting it in the motorcycle, no change, but it gets lower and lower as you increase the number of loops. So as a result of this system, you found that 2 alternatives on their own, consolidation and moving to truck loops, each of them had a small effect on their own, but together they had a synergistic effect leading to savings by using the truck loops and the zone sanitaire. And this resulted in actually a decision to follow that by the ministry. As an after product, they recorded here's the authors here who describe it in more detail. If you actually want to know how the the mathematic model work, you can talk to Bruce, but he's an expert in that area. So basically what CAS does, it helps us understand many things about dynamics, ranging from disease to health system context, understanding multi-sectoral factors, and trying to give us new approaches to both understanding and facilitating decision making. So my last slide here is that when you have complex systems around, you really want to try and find the simple rules around them. For implementation, this is my view of a simple rule. You take enabling contexts, which means adopting those cost-effective interventions and trying to find ways that build in systems that add flexibility to enable implementation. You take the cost-effective interventions, you add effective implementation, which again are these tools of iterative learning and changing and using data and involving all the key stakeholders of a system, sort of the content of how you actually use systems thinking as well as the tools, and with that we good delivery outcomes. So that's where we'll leave it.
Thank you. And our plan was to go right on and then come back to discussion later. And I say that keeping an eye out to see if anyone is just burning with a question for clarification. Not seeing that, we'll go on to Elizabeth. And please say a bit more about yourself, Elizabeth, as well as you get underway.
All right. Thank you. A story is told of a school teacher who was expecting a school inspector the next day, and she told her students, when the inspector comes, say, "Good morning, sir, madam," whatever the case may be. And the next day when the inspector came, the student stood up and said, "Good morning, sir, madam," whatever the case may be. So this afternoon I'll also begin by saying, "Good afternoon, ladies and gentlemen," whatever the case may be. And my names are up there on the screen. I'm a lecturer at Makerere University School of Public Health, and I've been doing research mainly in the area of maternal health and also health systems, and I'm also part of the Future Health Systems program. And this afternoon I'll just be sharing with you some of our practical experiences about doing a particular study, the safe delivery study, using systems kind of thinking. And that's a brief presentation outline that I'll be using. And we were doing this work in a context where there are multiple factors that affect access to maternal health services. Sometimes you find that mothers do not have transport to take them to the facility. Sometimes they get to the facility and there is no doctor, or the equipment is missing, or at times there are no drugs, and so they need money to buy the drugs. Sometimes, they're told you need a cesarean section, and that cannot be done at that facility. So that portrays a situation where you find that there are multiple problems, there are multiple issues that need to be solved, and just solving one, for instance, the drug problem, would not help get that particular mother to the facility. And so when we did an intervention, we tried to address both demand but also supply side issues. And so we used a voucher that was given for maternal health services, and then a voucher that was given for transport services for the women who were in the intervention area. And then in both the intervention and the control, we did some health systems strengthening initiatives. So that picture was taken in the evening. That was a sensitization meeting just to tell people about the program. Then the vouchers will be given out during the antenatal care clinic, and then if a mother wanted to go to a facility, she would get a motorcycle to take her there. That's the commonly used transport in rural areas, and some people get really shocked when they see that, but yeah, if you come to Uganda, you will understand that. So when the woman would give the voucher to the transporter, and after he has transported her, he gives it to the research team and then would pay him. And then the health facility providers would also get a reimbursement for each delivery that they did, and they were free to use that money according to their discretion to improve the services that were offered at the facility. So the basic objectives in this work was really to assess the effectiveness of this intervention in increasing access to maternal health services, but also to find out how the intervention would alter incentives for clients and providers, and what influence this would have on access to maternal health services. And in the interest of time, I'll just share with you two brief pieces of the results. We found that when we looked at deliveries, there was an increase in the deliveries. We did a short pilot that started around November, December of 2009, and you see the deliveries beginning to increase at that point. Then we did some review after that pilot, and then the final implementation was 1 year from June to June, and you see an increase there in the deliveries. And we also tried to look at some of the factors that were contributing to this increased delivery. And we found that there were several factors. One was the fact that there was improved actual and perceived quality. The health workers were more available, their attitudes towards the women were better, and so the women, were more satisfied with the services and utilized them more. There were reductions in formal and informal pay, so the cost of seeking services were lower for the women. There was increased transport availability and affordability. There were improved family relations and social support. The women say that in the past, when they were pregnant, some of their husbands would shy away because they were afraid of the financial responsibilities of having a new baby. So now that they had this project helping, they've instead encouraged them to actually go to the facility. And there was also increased awareness about the importance of seeking appropriate services. I recall a statement where a mother was saying, now I understand why our babies used to be sick, because at times you'd be in the garden and then your friend who has been digging and has dirty hands comes and helps you deliver your baby. So they were able to understand the importance of having a clean delivery. But we also realized that there were some unintended consequences. For instance, there are women who decided to change their fertility decisions. Because the project was there, they decided, I'll have more babies, or I'll have another baby because this project is there. Then family support, much as the men were providing more support, there are also those men who basically gave up their responsibility and decided, the project can do it, I don't need to do anything. And the transporters and the health workers also tried to find ways of cheating and earning more money. So, we had some intended consequences, but also some unintended consequences. And so you see that in that kind of situation, you're looking at multiple factors that are interacting and influencing each other in different ways. And so you ask yourself, what kind of methods should we use to be able to understand all these intended and unintended consequences? And we think that that is why we need to use more of a systems approach to our thinking. And in phase 2, when we went on to develop these programs further, we decided to modify the methods that we were using to allow us to be able to study this complex environment. And I'll just share with you about 3 of the methods that we are using. We are using the theory of change in a slightly different way from the way we usually use conceptual frameworks. And we found that the theory of change helped us to be able to clearly identify the pathways of change. If we expect mothers to deliver in the facility, how is that going to happen? What steps do we actually need to take so that we think through those steps and plan for them, so that we think through what are the assumptions that we are making, what do we think will be in place for this to happen. And reviews of that theory of change also help us to monitor progress as we implement, to ask ourselves, are things happening the way we expected? Is the change happening? If it's not happening, then why is that not happening, so that we can be able to correct that? And so we've realized that, when you use the theory of change, it shouldn't be a static tool that you develop at the beginning of your research or intervention and forget about it, but you can review it and you can update it so that it actually reflects the changes that you encounter. Then we are also using a participatory action research approach in one of the projects with the district as lead implementers. And we found that this has helped us to incorporate the views and opinions of stakeholders and to take consideration of this while designing and implementing the intervention. So it also helps us to reflect on what is happening and why that is happening. For instance, one of our interests was to get the men more involved. In countries like Africa, the men are really the main decision makers. So we really wanted to get them involved. And from one of the community dialogues, the women was saying, these men do not really value us that much, because if I die, then my sister is going to be sent to him. So he'll have another wife, he'll have someone to take care of his children, and his life will continue. So we realize, as long as that is there, the husbands may not value their wives that much. And so you realize that is something you need to think about and see how to address it. And then this kind of participatory approach also allows you to respond to the changes that you see. Sometimes when you're doing a randomized controlled trial, you're a lot more restricted, and you can't see something happening and decide to respond to it immediately in a manner that is appropriate. So that is a particular advantage. And then we also plan to use causal loop diagrams, and David in his presentation showed some of those diagrams, and systems dynamic models. And we expect that the causal loop diagrams will help us to be able to explain some of these changes and some of the interactions between these variables more explicitly. Because in the past, sometimes you get to know these things, but you're not able to present them in a manner that makes the interactions and the directions of the interactions between the variables explicit. Then the use of models, the participatory models like the kind he was showing, can also help us to be able to demonstrate scenarios that we cannot test in the field practically. For instance, in our case, like I said, we often use motorcycle riders, but at times you need to have a motorized ambulance to save the mother in time. So that kind of situation can be modeled so that you can, when you meet the policymakers, be able to tell them, if we use only motorcycles, we'll be able to save maybe 50% of the mothers who are in a critical condition. But if we add motorized ambulances, we can save 80%. And that would help for them to be able to see the relevance of the research, for them to be able to see the importance of different aspects of the intervention that you may not have been able to test practically, but can still be able to demonstrate. So as I close, I really want to say that we have found that the use of a complex adaptive systems lens when we are doing this kind of work can facilitate the understanding of intended and also unintended consequences that may occur in health systems interventions that many of you are also involved in, and that could help in the subsequent identification of appropriate strategies as we implement. Thank you.
Thank you, Elizabeth. And Rob, now our commenter, and then we open it up for discussion.
Thanks, Dave, and thanks to those who are now vanished from the screen, as well as the two human beings in front of us. These are great presentations. I just have 3 quick points I want to make. First one is that this complex systems analytic approach, I think it's absolutely a great way, the right way to think about these problems, David and Elizabeth and others in the room. And therefore, my second point is I think we need to see much more use of it. And my third point is, what can we do to get more use of it? And I'd just like to go back on those 3 items very quickly. You guys know this better than I do, but as a maybe a consumer of some of these techniques, wondering whether this is a good way to go in dealing with some of the problems that I have to wrestle with my staff and with my clients. I think that your manifesto or your argument, some of it's in your general materials, David, that by using systems analytic thinking, that we can predict better ex ante what the effects of some of these interventions or programs or policies might be, that we can anticipate better problems so they don't blindside us, and we can also understand ex post through evaluations of the kind Elizabeth was talking about, why things, sometimes much to our surprise, why they either work really well or why they come up short. And I think that trying to illustrate those benefits is very important to making the case for for this as a necessary that there are a lot of benefits here that should motivate more teams, more policy decision makers to go down this road. I want to just argue in terms of my second point that it should be used. I think it should be used more, this approach. I think that that using this approach in this whole area that you've already started exploring, which is around how to scale up things which are known to be good things in terms of health impacts, but we have trouble in many environments doing so, and also how to make these services more efficient. I think the example there around the supply chain for vaccines is both around a scale-up or completing the last stage of a scale-up in a country which is doing pretty well on its vaccination coverage, but also making the system more efficient. This would apply to this example of the mother-to-child transmission programs, which tend to fall down. It applies to the question of trying to expand the safe deliveries, the use of the SPAs, and so on. I think that this is a prime area where there are enough complexities going on that it makes sense to use it. It's not, to take the WHO example, it's in that sweet spot. Trying to use systems analytics to understand social health insurance reform, I don't know. And maybe there's some things which are relatively straightforward and where it's, again, not going to be as compelling. But I think a lot of these scale-up challenges that we face around the Millennium Goals and so on, where I know you've worked a lot, makes sense. I also think that applying this around understanding global policies and their impacts is important. I think it comes out in some of what you illustrated there around the Global Fund. But I just want to take another example from my day job, which is that we're working right now with the Global Alliance for Vaccines and Immunization, Gavi, on a whole series of policy simulations. One of them, just to give you a case of where I think we ought to be using your approaches, and we could do better probably, is that Gavi has said to us, well, maybe there are some vaccines that we've been supporting for the last decade, like the pentavalent vaccine. Maybe the prices come down, the market is mature. We should be exiting from that vaccine. We should no longer support it, even in poor countries. But now there are a lot of issues arising in people's minds and doubts. How is this going to affect the overall market shaping role that Gavi plays? Will manufacturers also exit and push the price up? What will be the manufacturer response? How will it will affect country adoption decisions if they're suddenly not receiving a subsidy from Gavi? Will they be able to afford and sustain this vaccine over the long run? It seems to me that's an example of a policy where these kinds of complex system simulations could help us a lot to think through the pros and cons of going down that road. And that sort of leads me to my last of the 3 points, which is we have a number of people here from organizations like USAID and big, very talented organizations that are supporting donors and governments in low and middle income countries. What can we do to introduce this approach more in the real decision environments? And can we do more to document the uses of CSA, its applications, and its consequences? I was a little confused, just to end on this note, with the two examples, which are fascinating to me. The one around the supply chains and this idea that perhaps by doing simulations and seeing that a combination of these two policies, either one alone wouldn't perhaps make much of a difference, but in a synergistic way, that could be just the answer, and so on and so forth. Was this all sort of a modeling exercise, or was this actually something that the country adopted, where we have the opportunity to understand how did it influence, if it did, the policies, and did it achieve its intended consequences, or did we get other surprises, unhappy or happy ones? I wasn't really clear, so maybe we could come back on that. And the same with Elizabeth's presentation, it seemed to me that you were evaluating a program, trying to understand the effect of the combination of these different vouchers, recommending some further refinements to the national program. I didn't quite see, maybe I missed it, but I didn't know what's the last chapter or the last written chapter in that story. Is the Ministry of Health paying attention to this, or is DFID or whoever, the funders, the World Bank, the ones who are supporting maternal and child health, is this feeding into their decisions? Are we finding that all of this very sophisticated and I think quite insightful analysis, is it finding its way into changes in the program in Uganda and making the sort of difference that you predict might take place if people were to absorb, to internalize these very interesting findings that you've come up with? Thank you.
Thanks, Rob.
Yeah.
And there's some questions there, which I hope David and Elizabeth will think about. But let's collect some more questions people might want to ask. Yes? And remind us of your name and where you're from.
Yeah, William Wells from the USA. I have a couple of observations that I'd just be interested in reactions from the panelists. So one is in terms of the kind of quality improvement cycle and using that as part of this approach. When I've seen that in operation, I think in theory it's fantastic and it can work, but in practice I've seen it where there are such ambitious goals that people are trying to measure against, like reductions in mortality, and the improvements that are being made are of a much lower level, and then connecting the two in a practical situation becomes very difficult. So I'm just curious if that has been a struggle in this area as well, where the interventions you're talking about and the objectives you're trying to reach, there's a bit of a mismatch. The second area, I wondered about when you were showing the slides with the different rates of decrease or increase in indicators, depending on the countries. And you can say, okay, it's a sign of complex systems where there's a lot going on. I wonder whether it's very substantially a sign of leadership. Again, that's an experience I've had multiple times where leadership is so critical to whether an enterprise actually makes it to the finish line. And so I wonder in this conversation whether a very important component is more like people who study social behavior and psychology and basically can inform that leadership element of this.
Okay, we'll collect a few questions, if that's all right, David,
Sure.
Elizabeth. Don't forget Rob's questions, too. Yes?
Hi, I'm Shandeepa Mukherjee from George Washington University, and somebody who's currently in the process of analyzing data to try to understand scalability of some innovations that are being done by the SC4CCM project. I'm wondering, in those models, in your equation, especially, David, your conceptual equation about enabling context times whatever, like, what variables are you using in your model? Especially like leadership, like what are we modeling? Like what actually gets measured and put in there? Because I have trouble figuring out how to do that in a really good quantitative way.
Why don't we take these questions so far and let you respond to them, and then we'll have another round. Who would like to?
So, sir or madam, whatever the case may be, can go first.
Okay, maybe just some brief comments on the first one about the last chapter of that story. I didn't get into that because of the time that we had. So in this particular presentation that I made, we're using vouchers that were being given to everyone in the area where we're working. Those were 2 districts. And at the end of it, we felt that this might be expensive for a low-income country to be able to afford. So when we completed the study, we decided to come up with 2 different projects that would move that work forward in a different way. And in one of them, the vouchers are being targeted to people who live more than 5 kilometers from a facility, because there's evidence that it's those who are far off who at times are not able to access services. And they're also being given as one-way vouchers so that the family can still contribute. And that was partly done to address some of the issues we noted earlier. And then community health workers were also more involved in the delivery of these vouchers because of the issue of fraud that we had noted earlier, because we realized that if this is to be scaled up, you have to deal with issues related to fraud. You may need to do some targeting. So that work will be completed towards the end of this year. And then in the other program, we are trying to work more with the community to see if households can save more money and be able to use that money to pay for transport rather than having to depend on a donor or depend on government. And we are also using an implementation approach where we are working with the districts and the community people themselves to manage some of those transport schemes. Because in the earlier version, it was mainly the research team that was managing. And then when you go away and you exit, those who are left are not quite able to manage that. So, as we continue with this piece of work, we'll come up with more specific lessons that we can share. However, while all that is happening, we say, this is a dynamic world. There were about 3 voucher projects that were happening in the country, and all of them showed that indeed vouchers are able to increase access to maternal health services. So the country has gone ahead, and some of the donors have been willing to support the voucher project. So there is a large pilot that is supposed to be beginning, and the Ministry of Health was in the process of getting different people to implement this voucher project. So some of these findings would finally contribute to how they're designing it to make it more effective. But the designing process is yet to be started. So we'll certainly be getting in touch and trying to contribute to that. So that's just to mention a bit about how this work is contributing. And the next step, there was a question about a mismatch between the interventions and objectives. I'm not sure if that was meant for me. I didn't get that clearly. Then just the issue of leadership, to say indeed we noted that leadership is very important. And in that first project, we found that facilities that had better leadership were able to utilize their money better and able to improve the services that we're offering more than facilities that did not have good leadership. So that was just to emphasize that indeed leadership is very important in this kind of initiatives.
Great. So, I'll just pick up on the last point, because I think that, using quality improvement cycles, for example, is a very good type of technique for being able to have rapid learning and rapid change to respond in short pieces. So it's a type of technique that's amenable to complicated situations. But the disparity between, or the gap between what you do is something at a micro level and a macro level, or a bigger impact, is a common type of expectation for a number of reasons. Everybody's expecting changes in mortality. But part of the reason why you want to have systems method is really to try to connect the dots. So a QI tool on its own, where you don't know where it's leading, and when you have expectations that don't fit in, is really a reflection of a good tool for some things, but you actually haven't been able to connect the dots and the things that come in outside. We tend to think in linear types of ways, but in fact there's many other kinds of concurrent types of factors that will affect things. So that's, I think that that's really more of a reason why you want to adopt types of systems thinking, to be able to see how the different pieces come together. And it may well be, it's very typical that, big interventions lead to small effects. That's often the case. And I would say that similar types of thinking would help to explain the diversity in outcomes of, or trajectories for countries, because certainly leadership is an aspect of that. There are other contextual factors, the fact that there are different actors in every place. You may have professional groups that object to something, or different delivery, different approaches because of different actors in the system. The context is quite different. And we actually tried to adjust for things like education and governance and political stability and things like that. And they still have different trajectories. So it's hard to model these things with simple techniques, and even in complex or more CAS models, it's difficult. I would say, Sangeeta, the model, the simple rules I showed at the end, that actually isn't a model. That's sort of my trying to show 4 elements. I don't know if we can show it up there, just that last slide of simple rules, because it's really 4 factors that interact with each other that I tried to show in a very simple way.
Right. Did you want to try and model those?
But yes, absolutely. But this itself is not a model. This,
no, it's just a way of thinking. But
right. These are sort of elements.
That way?
And I would say that what we've often missed is that we've spent our effort on trying to identify evidence-informed interventions through fairly fixed types of procedures. And we have not spent time on how do you actually do this, which is really that kind of iterative learning and trying to use data flexibly, but also the enabling context and how that means. And that is required. That does require leadership. That does basically set the permissions. But I haven't. This is a very loose type of mental model. It is not a very very structured model that I can use to translate this into a quantitative thing. But in terms of translating to a quantitative model, the good story about the Benin example, and I think Bruce should actually tell us a bit more, because this was very interactive. I don't know if you have the timeline slide there, but this was something where the modelers worked very closely in both defining the problem with the implementers, the policymakers, gathering the data, and then trying to actually run the simulations. And it actually ends up here with the decision actually being made. And they've done this in many countries with different kinds of questions, whether it's changing the size of the vial or different ways of affecting the supply chain. But in this case, the decision was actually made to go to that synergistic effect with the zone sanitaire. But Bruce, maybe you can tell us if it actually ended up being more efficient, and if you have other things you might, if you don't mind.
So I want to thank Dave for highlighting this work. So this is an interesting situation, interesting story, which actually highlights the evolution of thinking going from maybe single solutions to actually a systems way of thinking. So it originated because the Logivac project, which is a combination of AMP and WHO, funded by the Gates Foundation, had the initial goal of training more logisticians in the supply chain. So given, because the country felt that there was a deficiency in terms of trained logisticians and training them in procedures in terms of taking inventory, tracking temperature, those things that are required in the supply chain. But as they moved further and further along, they realized, well, the problem might be bigger than that. And that it wasn't just a matter of training more people. They might actually have larger system issues. So they knew that they wanted to improve the supply chain in anticipation of the new vaccine introduction. So the initial thought was just train individuals and maybe just add cold capacity where needed. But as this emerged, the Ministry of Health started realizing, well, this is an opportunity to look back and say, should we potentially redesign a system that was designed in the 70s, decades ago? Things may have changed since then. And then we slowly got involved in these conversations. And there was a lot of engagement with the Ministry of Health, in big part through the Logivac project, through WHO and AMP, because they were on the ground having lots of conversations and saying, well, we might consider this. And we basically went through a lot of different, because when you look at redesigning the system, there are many different options, right? You could really mix and match, and there's hundreds of locations. But they wanted to come up with a solution that was also viable when it comes to administrative boundaries, when it comes to politics and human resource issues. So ultimately, the Ministry of Health, with interactions with us as well as the other partners, came down to a finite set of options, and then that's what we evaluated. And once we evaluated those options and found that one of the options seemed to be a win-win situation, it was the least expensive to implement and also had the lowest operating costs. Then, since then, the Ministry of Health has progressively implemented that in different locations. So it's kind of a slow rollout. They can't make the massive change all at once. So the first step was actually to convince the donors that this was a viable idea. So during one of the meetings, not only did we have the Administrator of Health there and the Minister of Health, but also all the partners that we mentioned before, as well as all the major donors, because some of this was also to advocate for this change. So if the donors are going to contribute money or contribute equipment, they need to see that this was a favorable situation. So part of this exercise or the modeling was also to convince other donors and bring everyone on the same page. So what's been happening is they've been fully implementing this in Benin, and our partners are in the midst of tracking the changes and tracking the improvement as well. So so far things look good. It hasn't been completely fully implemented throughout the whole country, but there's been regions or parts of the country where it's been implemented.
And is it cheaper?
Yeah, I mean, they're finding, so certainly by reducing the number of locations, you essentially are reducing the personnel required. So the training has gone down, and the human resource expenses are going down, as well as the you have fewer equipment that you have to maintain. So those are obvious initial benefits. To measure sort of longer term benefits will take a little bit of time, but those are obvious things right off the bat. So a lot of what they're interested in right now, because those are no-brainers. If you have fewer people and fewer equipment, you're going to be spending less money. What they're interested in seeing is kind of the long term. Are they able to maintain the vaccine supply and coverage? That takes a little longer to measure. So.
Great. We'll do a second round of questions, and I can't resist asking one myself. I'll start with, imagine a thought experiment where we had collected in a room next door the 100 best researchers of all time on these kinds of questions. Best in the sense that they're conceptually very thoughtful and also very practical. So they had a sense of policy and programs and so on. They all understood the world is complex, and that the challenge is to find what's important in all the complexity and extract from that information, knowledge that advances our understanding, our ability to solve problems. And imagine that out of those 100, some of them were users and great advocates of health systems research, as you defined it, and others not. And let's suppose that those who are advocates were explaining to those not what was the additional value added. And those who were not were saying, well, I've thought about the problem, I've been incorporating the complexity. What's the added value there? So that's my question, but while you ponder that one, let's see. Yes?
Thanks for the presentation. Super interesting. I guess it's two questions in one. It seems to me that complex adaptive system research or implementation research requires a good documentation understanding of unforeseen processes and consequences of programs. My first question is, how do you design research to take that unintended things or things that you haven't thought about ex ante? And the second question is, especially from Elizabeth's story, from that program, it seems like you have to be on the ground watching everything in order to pick up on all of the things that you didn't foresee. How do you do that for a really complex program or a large scale program?
Sarah?
I wanted to respond to Rob's last question. I'm not sure about how to get greater support for this kind of work. I wanted to respond by sort of reflecting a little bit on some of the challenges that I think that we face in doing this work. And I guess it's based upon the experience of FHS to some extent, not all of the comments. But there seem to me to be a few problems. And first is sort of more a reflection on the fact that I think that many international agencies have placed a much stronger emphasis in the past 5 to 10 years on evidence-informed decision-making. but frequently that has been looking at sort of very high quality evidence, and I think within the health community we've ended up with a very narrow notion of what high quality evidence might mean. And so we're particularly concerned about randomization, about impact evaluations, and I have a concern that we've squeezed out some of these other types of evidence which might come from implementation research or other types of research approaches, and that we really need to make sure that we're using a whole broad array of research techniques to address these challenges. The second point that I wanted to make, I think it's come up already, is that I think that this is an area which many people understand intuitively. So when you start talking about the concepts and the construct, it all makes sense. And when you start beginning to use some of the sort of more qualitative tools that Elizabeth was talking about, they also make sense. They resonate, they're not too complicated to use. But I think being able to move from that to the more sort of quantitative analysis that you were talking about, Sangeeta, is the place where it seems risky, it seems difficult, and it seems like a stumbling block to a lot of people. And you know, on the future health system side, we've just come from a sort of 3-day workshop where we've brought in a number of modelers from across the sort of Hopkins community, many of whom have been outside the International Health Department. And I think, you know, recognizing first of all that there are a ton of experienced people out there, maybe not a ton, but there are experienced people out there. And secondly, that this work, almost by definition, needs to be done in teams. It's not something that health systems researchers can do on their own. Is, I think, really critical and really helped us move forward and think much more concretely about how we might be able to approach more quantitative modeling of some of these types of research questions. And the third point I was going to make, and it actually picks up on what Manuela was just saying about the need to be on the ground all the time. I don't think that's true for all of the kinds of research methods that one might use within to do sort of complex adaptive systems type approaches. But it's perhaps more true than some others. And I think certainly for implementation research, being able to understand the context, to be able to respond to questions that arise during the implementation process from implementers, from policymakers, does take being sort of more rooted in countries than might be the sort of typical modalities which are often used for doing sort of research. And I think it means that we really need to build strong research capacity in the countries where we're working to be able to do this kind of work. And that obviously is a fairly big undertaking in some contexts. It's important to think about.
We have time for one more question, because we'll then come back to the panel, including Rob, if you like. And April, your hand went up, so you're the last question.
Yeah, I just totally agree with everything you just said, Sarah. So, as you're all, I mean, I'm completely on board with everything being really important, and there needs to be a lot more of it. So I'm not criticizing that. But as we're talking about this complex adaptive systems, I was sitting there thinking, well, if complex adaptive systems is the answer, then what was the question? And I'm serious. I mean, because I think the question is, or what was the question? Was we need to understand these systems that we're intervening in with our hundreds of millions of dollars to try to accomplish various things, and we don't. We don't understand them well. So I think just putting this out there is already a huge step in the right direction, because it's drawing to our attention the superficiality of our understanding. I think that's huge. But there are also other domains of knowledge that can be extremely helpful for informing that very important question. Complex adaptive systems is wonderful, but I think there are a lot of questions about institutional arrangements that can be informed by other domains. And the one that comes to mind, just because it's fairly well known, is that, was the work of Elinor Ostrom in helping us understand common pool resource systems. She never did a single intervention study, right? And her and many others. But what they did was cross-country comparisons with many people working together. It's basically lots and lots of case studies over years and with much deeper theorized questions about where you saw common pool resource systems working, what was causing that. And then they started, once they had that, then they started to do some experimental studies to sort of test whether they really got it right. We think we now understand, let's go test, is it really this communication that's causing these particular common pool resource systems to be able to deliver better outcomes? So just to say that there's other domains out there of knowledge that I think, especially for health service delivery stuff, service delivery organizations of all different kinds are going to require different types of institutional analysis. And I'm all on board with the complex adaptive system stuff, but I think we need to recognize that there's a lot of other knowledge domains that we need to draw on if we're really going to move forward.
Great, thanks. So I think the last word goes to the panelists. Elizabeth, do you want to start? And one advantage of having lots of questions, you can pick the ones you want to ask.
That's very wise advice. So some of them are comments which we agree with and we appreciate, by Sarah and the last speaker. So I agree with those comments. Maybe I'll respond to the one about unintended consequences and so on, and how you can anticipate them. And I want to begin by saying you're right. You can never anticipate everything that will happen, because people will change their behaviors. They'll decide to behave in ways you didn't think that they could. So ex ante, you anticipate some, but you may not be able to anticipate all. And so you have to keep your ears and eyes open to see what is happening, and to keep engaging with the group you're working with to actually get feedback and see what's happening. But having said that, one of the things that we found helpful ex ante is actually engaging with the stakeholders before, because to some extent, they know their local settings, they know how people tend to respond, and so at times they'll tell you, if you do this, that is likely to happen, or if you do this, that is likely to happen. So you're already kind of warned, and so you realize we need to watch this space because this is likely to happen. And then the last thing is the fact that if you're implementing some of these interventions, you need someone on the ground to make some decisions. Because a situation will come up, even for us in Uganda when we're in Makerere, they can't wait for us to decide on something. And if you're in the US, it's even worse. They can't wait, until next year when you're coming for the annual meeting. So we realize it's important to build the capacity of the local people who are in that particular area where you're working, so that when something comes up, they have the capacity to make to make some wise judgment and see what to do in that situation. Because like we say, this is an environment where things will happen and people are going to respond to those changes. So it's important to build their capacity to make the best possible responses. And you review that and see how you could have made that better, or how you could have avoided it if things went completely wrong. I think those are the comments.
Thank you, Elizabeth. David?
Sure. So I would say that first of all that this field of groups that use systems thinking is actually very ecumenical. And just 2 days ago, we had somebody who's trained as a physicist and an anthropologist explain to us how Eleanor Ostram's work is actually systems thinking. So it's not actually bound by by disciplinary boundaries. The examples we gave may have been more rooted in one case in mathematics and engineering approaches, but they don't have to be. You see the full range of things being employed. It's in a sense partly there is an approach to thinking about systems and how they fit together into whole, which of course is hugely a concern of many disciplines. The enterprise is trying to understand how and why things work and changing it. So that's not unique to epidemiology, economics, engineering, etc. So I think that's one of the advantage of this broad thing. So what's new is there are new methods, new tools, as well as old methods that come together. And I would say that in many cases, the modelers were explaining to us that you actually want as simple as possible to start. And so many of the systems you try and build to illustrate behaviors, often counterintuitive, are very simple. They just have a couple of agents and a couple of rules. I think it's true that, like Sarah pointed out, that when you're dealing with implementation and evaluation, you often do have to have larger models to try, if you're trying to evaluate something that's going on. But I think Elizabeth's answer is in terms of, well, then you actually have to keep going back to your key actors and finding out who key actors are that are emerging to try and find what those main unintended consequences, because you can't pre-specify everything beforehand. I mean, we can't, if everything were that deterministic and you could figure out everything, that that would be great. We wouldn't actually have to do a lot of the research, but you can't do it all. So moving to the thought experiment, if we could find the 100 best scientists, I think the main advantage or the added value of using systems thinking is really in terms of taking people's implicit and understood models and making them explicit. And when you do that, you are then able not just to predict things, but also to try and understand how they work. You can test them, you can corroborate them, and you can actually do things, trying to identify phenomenon that other types of scientific can't do on their own when you bring them together. And we particularly are not very good at doing things that involve dynamic, multiple agents, multiple things that are changing at the same time in different ways. And so that's really the advantage of trying to bring these kind of approaches is being able to then have common understanding, common assumptions, well, maybe not common assumptions, but at least explicit. And then you can work from there and debate, discuss, test, corroborate, and whatever other method you bring, you can address it. So that's, I think, the main advantage.
Anything to add, Ron?
Just quickly, when I hear to respond to what Sarah was saying, when I hear the examples from Benin and from Uganda, I feel optimistic. I feel uplifted because these seem to be examples, if they're well documented and seen through to the end, of where the use of this systems thinking conceptually, qualitatively, and some quantitative aspects can be brought together. So maybe there are grounds for hope and optimism there if we can see some of these examples through. It seems like, David, the other side of using this approach and using it not as a short 6-month or 12-month thing, but as a continuous way of doing business, is that it ties in very nicely with your idea of a kind of a learning approach to reform rather than a blueprint approach. We haven't used those terms here, but I know that's one of your big themes. And it seems we're talking about complex adaptive systems, but I was thinking about complex adaptive policy and program making. And that's the other thing, is the idea that we do a piece of analysis and then we know the answer and we're done. And so if somehow this can be a part of an adaptive way to improving programs and policies, I think that's also the trick. But that requires really a continuous long-term internalization of this approach to the way in which business is done. I don't want to end on too much of a down note, but I just wanted to say that one thing that kind of struck me when I heard about these two examples from Uganda and Benin that talk about the fact that in the case of Uganda, the vouchers looked like on a small scale they worked, but who was going to pay for them and could they be afforded on a national scale? And I also heard, Bruce is gone I guess, but I also heard that the donors had to all be brought together to be convinced that this was something worth investing in. I don't know how we think about in our modeling how we think about the problem of financial sustainability here, because where a lot of this analysis is going on in environments in which even if it looks like something can be modeled to work and then can be demonstrated to work in a real life experiment, the environments are also very fragile in terms of financial as well as institutional sustainability. And I don't know how you incorporate those into these models, but I think that could be also a little bit of an Achilles. Now he walks in just as but I think that could definitely be an Achilles heel here. And I think at some point we need to think about that as well as we go forward.
But actually, sorry to interrupt, but the questions of growth and sustainability are actually two of the main types of questions that you want to address with systems thinking. And so that's really why you do these models, and those are two. So I would say that's not the Achilles heel. That's really something. That's really a reason to bring these techniques into application.
We've unfortunately reached the end of the time, so I would like you to join me in thanking our panelists, including the two who are on the screen. Also to everybody here and to the wonderful institutions that you're all connected with, Johns Hopkins, IDS, USAID, and lots more, Georgetown, lots of universities. So thank you very much.
Thank you. Thank you. Yeah, it's, you know, the guy who wrote this book. Yeah, sorry, I don't know what I think it had to be. I would just write it another way down. It's actually.
Come in.